Hopefully that's working to record the narration for the people that aren't here. So I'm Becky, for those of you who don't know. I'm going to talk to you about biochemical tests and interpreting them. I bought some sweets, and that's kind of a bribe for you not to heckle me. So please, if you have questions, feel free to ask, but I'll just warn you now, I've forgotten everything that I need for finals. So we're going to go through full blood count and hematinics, using these LFTs, inflammatory markers, and then a few spot diagnoses for you for your exams. And then at the end I've done a little slideshow practice, because I used to like it when they did that last year. So just things to remember, this is really important for your finals, because you'll definitely get something to interpret, you know, an ABG, although I'm not actually going through ABGs today, just a set of blood results, and then when you start working you're just always going to have to chase results. It's just a daily thing that you'll always do, and you actually need to like start kind of realising what you're looking at rather than just kind of looking whether they're high or low. Things to remember as well, treat the patient, not the numbers. So rather than just looking at the numbers in front of you, you need to actually go and see the patient and check that it kind of correlates, and we'll talk a bit more about that later. Look at trends. So if you've ever looked through blood results when you've been on placement, you'll see they'll always press that little button that brings up the trends, because on their own blood results are pretty useless. You kind of need to look at them to see what the trend is over the last few months or last few days. In exams you should be given reference ranges. A fourth year told me that she wasn't given, a fifth year told me that in fourth year you weren't given them, but we were certainly given them in our exams. But it's just really important to know the basics for when you start working. So things like a potassium of 7, you should know that that's high, or like a sodium of 120, you should know that that's low. But specifics don't really worry about, especially things like LFTs, it doesn't really matter. And then now you should start to act on results. So rather than just, like I said, rather than just looking at them, you should know what to do about them. So like I say, if you have like a high potassium, you should know what to do about it. So it's kind of the transition from third year to fifth year, and when you start work you need to know actually what to do about them. So full blood count, there's lots of different things that make up the full blood count. These are the ones that I think you need to know. These are certainly the ones that you look at when you start to work. There's lots of different things as well, but that's kind of for hematologists, so I wouldn't worry about them. Just focus on these and make sure you know what they mean. So first of all, HB and MCV. So you should always look at them together. In surgery they don't really tend to, but in medicine they do. And MCV is mean cell volume, and that essentially tells you the type of anemia. So if the HB is low, that's obviously anemia, and then the MCV will tell you the type of anemia. So if you think of mean cell volume as the average volume of the cells, so on average how big they are. So if it's normal, you have a normocytic anemia. If it's low, you have a microcytic anemia. If it's high, you have a macrocytic anemia. And then I'll talk just a little bit about red cell distribution width. It wasn't one of the ones that I mentioned before, but it's something that would make you look a bit clever if you know what it means. So just to go on to the causes. So always just try and remember a couple of causes for things. So microcytic anemia, the one that you'll come across most commonly is iron deficiency anemia. For macrocytic, it's B12 and folate, but there's a whole list here of different causes. The way that I kind of remembered it last year is B12 and folate are involved in DNA synthesis. So if they're deficient, the cell's kind of not going to be formed properly. So I always imagined it was like formed abnormally and really big and weird. So it's macrocytic. Then microcytic, the cells are very small, and then those are the causes. And then normocytic, the cells are kind of normal, so the size of them hasn't changed, but they're just less. So you're anemic, but the actual size of them isn't any different. So if there's blood loss, if they're hemolyzed, they're broken, if there's chronic disease, like if you have chronic renal failure and your kidneys aren't producing erythropoietin, then you're going to have less of the red blood cells, but they're not any different, so they're normal in size. And the reason I mention red cell distribution width is because you could have a B12 deficiency and you could have an iron deficiency. There's no reason to stop you having both. So you'd have some big cells and some little cells. So the MCV, the mean cell volume, or the average size of the cells, would be normal. So then you'd look at the red cell distribution width, which tells you the distribution of width, so how many different types of width there are, how many different sizes. And if it's high, that could tell you, so if there's a normocytic anemia, and the red cell distribution width is high, that could be because there's some big, there's some small, so the average is normal. Does that make sense? Okay, good. That just make you look a bit clever if you knew that. So hematinics are what you'd order if someone was anemic and you didn't know why. So obviously if someone had just had a massive hemorrhage, then you probably wouldn't look into the cause of the anemia. But in medicine, you'll come across so many people that are anemic, and so these are the things that you need to order. So ferritin, B12 and folate, and that essentially tells you the cause of the anemia. Something to remember about folate and B12 is that you should always replace folate before B12, and that's basically because you can get something called subacute degeneration of the cord if you replace the B12 before the folate. I don't know the pathophysiology of it, but it's something that happens and just something to be aware of. So always replace folate before B12. So we've also subacute degeneration of the cord. It's just a neurological condition. So talked about low HB, so now talk about raised HB. That's called polycythemia. So there are two types of polycythemia. You can have absolute and relative. So absolute means that the actual number of red blood cells is increased. So that's the cause, in things like COPD, where your body's craving that oxygen and can't get it because you've got a lung condition. So it tries to make more red blood cells to get more oxygen. So the amount of red blood cells increases. And then you can have relative polycythemia, where the actual number of red blood cells is the same, but there's less plasma volume, so things like burns, dehydration. And the way that, if you can't really understand it, think of a glass of squash. So if you have absolute polycythemia, that's more squash. If you have relative polycythemia, you have less water, if that makes it more clear. And yeah, those are the causes like I mentioned. So anemia is the one you'll see more commonly. You won't really see polycythemia very commonly. If you do, you would be getting a hematologist involved unless you knew there was a cause. For example, if you knew the patient with COPD, then you would accept that that was the cause. But otherwise you'd be contacting a hematologist because they might want to venesect the patient, where they essentially bleed them to get rid of the amount of red blood cells, because people are at risk of clotting because it's more coagulable. So actions for anemia, like I say, you'll see that much more commonly. This is the kind of classic of treat the patient, not the numbers, because a patient could have a really low HB but could be completely fine, whereas someone could have a HB of like 90, 100, be really short of breath, be really lethargic, they could have chest pain, i.e. be really symptomatic with it, so then you would want to treat them. So as a rough guide, below 8, does anyone know as well that it's changed? It's not like 8, 9, 10 anymore, it's 80, 90, 100, yeah. So if it's below 80, that's when you think about transfusing. But like I say, you always treat the patient and not the numbers. And think about if they were going for, say, surgery, where they're probably going to lose a bit more blood, then you might want to transfuse them before the surgery or maybe during the surgery. And this is another case where you would always look at trends. So I'll just give you an example. So this person's HB is 80 on the 11th. You look at the trend and you see it's quite a significant drop from the day before. So then you want to see the patient, see if they're symptomatic, but ultimately you probably would transfuse this patient because it's quite a significant drop from the day before. But it would just, seeing the patient just always makes you think how quickly you want to act, because if you saw this blood result, quite a lot of the time we chase bloods at night, and you trace this at say 11 o'clock at night, and the patient was absolutely fine, you wouldn't do anything about it because transfusing out of hours is really unsafe, because you'll all know about transfusion reactions. So this is when I say treat the patient, not the numbers. So example 2, exactly the same situation, look at the trend, and it's pretty chronic, so you probably wouldn't really do anything about that. You just might want to investigate the cause, see what's been going on, see if the GP's done anything about it. So moving on to platelets. So we've got thrombocytosis, which is high platelets, and thrombocytopenia, which is low platelets. So causes of an increased amount of platelets things like infection, bleeding, malignancy, and trauma. So platelets are an acute phase reactant, so they go up if there's infection or inflammation. So pretty much all of my surgical patients have high platelets, and I don't do anything about it. It doesn't bother me. If they go above 1,000, you might start worrying about this thing called essential thrombocythemia, which is when you just kind of get this abnormal proliferation of platelets. And because they're abnormal, they don't do what they should be doing, so they don't cause like clotting like they should do. So you get bleeding, but then because there are all these abnormal cells in the blood volume, then you can also get clotting. So there's lots of different causes, but essentially, like you would get a hematologist involved. So as soon as you see it getting higher than 1,000, you'd ask for help. So thrombocytopenia is low platelets. So that can be either due to decreased marrow production or excessive destruction. So there are immune causes and also non-immune causes. I haven't written a lot about it because it's kind of something that you don't really need to know about, just to be aware of it. And the treatment would depend on the cause. So for example, if it was an immune cause, so your body's kind of attacking the platelets and destroying them, then you'd want to use steroids as the treatment. If it's an acute cause and the patient's bleeding, then you would treat by giving more platelets. But again, you would never just do this. You would never just see low platelets and give platelets. You would always contact a hematologist first. And just something to be aware of when you start working, pretty much all your patients will be on antiplatelets as VT prophylaxis, so tinzaparin most commonly in Leeds. And if someone's got low platelets, you don't really want to be giving an antiplatelet, so you would think about stopping that, but the pharmacist would come along with their purple pen anyway and tell you. So white cell count is quite misleading, I think, because it can be high or low in infection, so it's not the most useful, but the surgeons love it. They look at it all the time. So essentially, if you see a high white cell count, you're worried about infection, but it's not very specific because it can also be raised in inflammation. So if you think about your SIRS and your sepsis, you could have a high white cell count in SIRS, but it doesn't mean there's an infection going on. To be sepsis, you'd have to actually find a cause for the infection. If you get a swinging white cell count or a swinging pyrexia, you'd think about an abscess. So again, in surgery, when people might have an intra-abdominal collection or some abscess somewhere, then you'd worry about that if there was a swinging white cell count. So that literally just means it going up and then coming down again, going up and coming down again. So just more about white cells. Obviously, you'll know that there's different types, the granulocytes, agranulocytes. So you've got your neutrophils, eosinophils, and lymphocytes. You'll remember probably from fourth year learning about neutropenic sepsis in patients having chemotherapy. Now, obviously, that's something that you really need to be aware of, not just in patients with cancer, but any patient. We've got a patient on the ward at the moment who's leukopenic and kind of getting hematology involved about that. They're busy people. And just other medications can cause leukopenia. So it's just something that you need to look out for because it's quite dangerous because people are at very high risk of infection if they don't have the white cells to fight the infection, especially when you're in hospital. So euthanasia. So your euthanasia are made up of potassium, sodium, urea, creatinine, and EGFR. So potassium, first of all, I'm really sorry, you've probably done hyperkalemia to death. Everyone seems to mention it, so I won't go into too much detail. But these are the main causes of hyperkalemia. Thinking about the actions that you would take if you saw a patient, if you were chasing results and you saw that they had a high potassium. If it's borderline, so if it's between 5.3 and 6, you tend to do an ECG to look for ECG changes. Give fluids, because most commonly in hospital it will be due to AKI, and repeat it. and unless you saw ECG changes, you probably wouldn't treat. You would only really treat if it's over 6. So then, you do your ECG, get your calcium gluconate, your glucose and your insulin, and salbutamol nebs if it's really high and you want to get it down quicker. So I've just included this slide because I found this really useful as a way to remember the things that happen on an ECG when someone has hyperkalemia. So if you imagine somebody has a piece of string and they've tied it onto the T wave, and then they're pulling it like that or like that. So the T wave becomes tall and tented as it gets pulled up. The QRS becomes prolonged. The P wave becomes flattened, and then finally you get asystole and they're dead. So that's just a good way to remember the changes that occur in ECGs with hyperkalemia. Does that make sense? Okay, good. So hypokalemia, again, something that we see very commonly. Just also, hyperkalemia, when I was in your position last year, I felt like it was something that was like a massive emergency, and everyone would be like, they've got hyperkalemia, we need to act now, but it's really not. It happens all the time, and it's not really unless it was above 7, you can probably just take your time with it. But again, hyperkalemia is something that we see all the time. If it's borderline, say 3 to 3.5, you just give something called Sandoz, which is an oral supplement. Apparently it's really horrible, and so some people will refuse to take it. So always look at their drug chart and make sure that the nurses haven't written a little 3, because obviously if the patient's not taking it, it's not going to work. If it's less than 3, or if the patient isn't tolerating oral supplements, you'd give potassium IV. Things to remember with giving IV potassium, firstly, you can't give it in Hartmann's because Hartmann's already has potassium in it, and secondly, you can't give it too quickly. So for every 10 millimoles, you shouldn't give that quicker than an hour. Potassium comes in bags of 20 millimoles, so you usually give either 20 or 40. So don't write 10 millimoles because you'll just get bleeped by the nurses because they won't give it. So if you're giving 20, you wouldn't give it quicker than 2 hours, so you'd always give it 4 hourly, 6 hourly, 8 hourly, 12 hourly, whatever. So that's just something to remember, and just be really careful because you could see a patient with a low blood pressure and say, put this bag through stat, and then it's got potassium in and they die. So just be really careful. These are the causes of hypokalemia. Most commonly we see people with diuretics, so it's just flushing all the potassium out really. And then hyponatremia, so moving on to sodium. We don't really see this that commonly. Usually it's just iatrogenic, so you're just giving them too much saline. Just always remember that normal saline has a lot of sodium in it, more than you really need. So it's usually you just kind of stop giving them the IV saline and just aim for oral rehydration. I find sodium really confusing because it's kind of dependent on how much water there is in the blood as well as how much sodium there is. So if you haven't got much water, i.e. the patient's hypovolemic and dehydrated, the sodium could go up kind of falsely, so then you give more saline to correct it. But like I say, it's usually just because you've given too much saline in the first place. It's not usually, you don't usually see it in hypovolemic patients. So don't panic too much about that. It doesn't really happen very often. So moving on to hyponatremia. This is the one that's a bit more complicated and we see a lot. So I'll try and explain it. So basically, when you see someone with hyponatremia, you have to categorize them. So they're either hypovolemic, so they're dehydrated, they're hypervolemic, so they're overloaded, or they're normovolemic, so we're normovolemic, we have a normal blood volume. So these are the causes of hypovolemia, normovolemia, hypervolemia. And then we'll just move on to what you would do about them. So you would assess the patient's volume status and decide which one of those 3 things they are. You'd always look at their medications as a cause for their hyponatremia, because things like diuretics, again, would just flush out the sodium. Things like omeprazole and antipsychotics and SSRIs, they can also cause hyponatremia, so you'd always look at their drug chart. And then if the patient was hypovolemic, then you would just replace the sodium. So just give IV saline, and you can normally give that quite quickly because it's normally an acute thing. So like if maybe they've been ill by mouth or they've had DMV or something, so they're just hypovolemic, so just give them some normal saline, it's fine. But just never give saline too quickly in people who are hyponatremic, because you can cause central pontine demyelination. Again, very rare. I've never seen it. I've heard about a case in a child, but that's basically when the myelin around the nerve cells breaks down because of this rapid replacement of sodium. So it's just really important that if you think this has happened over a gradual period, you should replace it gradually. But that's more common in patients who are euvolemic as opposed to hypovolemic. So in a patient who's hypervolemic, so all your failure patients, your liver failure, heart failure, renal failure, they'll be really edematous. So to solve that problem, you fluid restrict them. And in euvolemic patients, these ones are a bit more complicated because it can be caused by SIADH, so syndrome of inappropriate ADH secretion. And that's when you think about doing paired osmolalities. So your serum and your urine osmolality and your urinary sodium. So that's a way to find out whether the patient has SIADH. And again, if you're worried about that, you'd be calling an endocrinologist for advice about treatment. I don't know how to treat SIADH. SIADH can be caused by things like small cell lung cancer, because this type of cancer secretes ADH autonomously. Or it could be to do with like a pituitary tumour that's secreting the ADH. So if you think about ordering these tests, you're looking at how much sodium's in the urine. So if your body, if there's something wrong with your kidneys, say, and it's flushing out all the sodium, then you're going to have less in your blood and more in your urine. So then you kind of can work out where the problem is. So that's a brief summary of hyponatremia. So urea and creatinine, if urea is raised on its own, then it's dehydration, but remember that it can also be raised in GI bleed. Raised urea and creatinine together indicates renal failure, and that's where you again would think about looking at the trend. So if you just saw that a patient had a raised urea and creatinine, then you would want to look at the trend of it, because that would tell you whether it was chronic or whether it was acute. Patients with acute renal failure tend to have a high potassium as well, because the chronic patients will be having treatment, so they shouldn't have a raised potassium. So we had a lecture the other day about AKI from a consultant nephrologist, and he was just like, if you see someone with AKI, give 1 litre, 0.9% saline over an hour. And obviously we know that there are loads of different causes of AKI. You've got your pre-renal, your post-renal, your intrinsic, but 99% of the time it will be pre-renal in hospital, because they're dehydrated, because they've been ill by mouth, or because they're just not drinking because they feel sick. So just remember that, always just do that and you'll be fine. Even if you're worried about like heart failure or something, like you can give it a bit slower, but that's kind of your standard treatment for pre-renal AKI. So just another example. So you've got your set of results. So the potassium is normal, the sodium is normal, creatinine and urea are high, and EGFR is low. So you look at your trend, and you can see that it looks more to be chronic, because over the last month or so it's been quite similar. So if you actually look at the trend, you can see that this is a chronic renal failure patient. And then exactly the same situation, apart from this time the potassium is high, so it's more likely to be acute, and you can see that the day before the patient was fine, and then the day after that they've gone into renal failure, so this is acute. Just something I didn't mention when we were talking about hyperkalemia before, always look at the patient's drug chart and cross off things which you think could be causing the hyperkalemia, so things like potassium-sparing diuretics. And the same with acute kidney injury, always look at their drug chart and cross off things which could be aggravating it, which hopefully you've already gone through in your renal lecture. So LFTs, these are my worst, I hate LFTs. So bilirubin, ALT, AST, alk-phos, albumin and gamma GT. So bilirubin first of all, so you get bilirubin from the breakdown of heme and hemoglobin. Then that goes to the liver and it gets conjugated so it can be secreted in bile and then into the intestine and out for your poo. So it's to make it water soluble so that can occur. So if that doesn't occur, it will spill out into the blood and the level in the blood will go up and you'll get jaundice. So alk-phos is found in bone, placenta, and also in the biliary duct cells. So it can be raised when there's obstruction of the bile ducts, in bone diseases or just in growing children where the bone's being remodeled, and in pregnancy because there's presence of placental tissue. So it's not very specific, but usually, you know, if someone's got like right upper quadrant pain and raised alk-phos, then you probably won't be thinking that they've got like a problem with their rib or something. You would be thinking it's something to do with their bile ducts, like gallstones. Then ALT and AST. AST again is very non-specific because it's present in red blood cells, cardiac and skeletal muscle, and also is raised in acute liver damage. So in these certainly we don't look at AST, we only look at ALT, because ALT is specific to hepatocytes. So if hepatocytes are damaged, it will be raised. And then gamma GT again, it's not part of the standard LFTs in Leeds, but just so you know about it, it's raised in chronic alcohol toxicity, and it's also raised when there's subclinical levels of liver dysfunction. So it's just not really very useful. I'm sure probably hepatologists probably look at it, but it's not part of the standard LFTs, but just so you know about it. So so if there's raised ALT and AST, like I said before, it'll be a hepatic problem, a problem with the hepatocytes. If there's an obstructive cause of like jaundice, then there'll be a raised alk-phos and gamma GT, and those are the causes. So that's if someone's got jaundice, but hopefully they'll either talk through it with you in your liver one, or you've already had that lecture. But those are just to kind of demonstrate to you what would be raised in the different causes of jaundice. And then if you have a mixed picture, so you have like raised ALT and raised alk-phos, then you'd be thinking about ascending cholangitis. I've just got a picture kind of to demonstrate it. So the green dot is a gallstone in the cystic duct, so that's just blocking the biliary duct cells. So you'd get a raised alk-phos and a raised bilirubin. And then the red dot is to demonstrate a gallstone in the common bile duct. So if there's a gallstone there, you can imagine everything backing up into the bile duct and also the liver. So you'd have damage to the biliary duct cells, so a raised alk-phos, and damage to the hepatocytes, so a raised ALT, and a raised bilirubin, and the patient would be jaundiced. And so you get Charcot's triad, so they have right upper quadrant pain, because obviously that's the region where the gallstone is. They get jaundice and they get fever, and the patients are really unwell when they have this. Whereas a gallstone in the cystic duct, they'll just have like biliary colic or probably cholecystitis. So just a bit about inflammatory markers. All of these are inflammatory markers. The ones that we look at in test results are CRP really commonly, or the audit CRP when you're doing surgery because they like to monitor it. And that's an acute phase reactant, so in the acute instance that will go up. ESR is more commonly used in chronic conditions, so it's monitored in things like rheumatoid arthritis where you'll have chronic inflammation. Although in Leeds they use plasma viscosity, which is PV, instead of ESR. But all of these are raised in inflammation, so like I said before, the platelets and the white cell count, and ferritin as well is raised in inflammation. And D-dimer, so you might have heard before about how D-dimers are just really non-specific and pretty rubbish, and you shouldn't just order them willy-nilly because they're really non-specific and quite annoying if someone hasn't actually got a DVT or a PE. So, spot diagnosis. So we've got raised potassium, low sodium, normal urea, normal creatinine, normal EGFR. I kind of want to open it up to the floor, but then I don't want to freak people out if they don't know. Does anyone know? Yeah, Addison's. So that's just kind of spot diagnosis. Like, obviously there's very little information there. But as a rule, if you have high potassium and low sodium, it's Addison's. Or you'd worry about Addison's. And the test that you do is short synapsin test, which is when you give synthetic ACTH, and that's called synapsin. So you'd take some cortisol, then you would inject them with the synthetic ACTH, and then half an hour later you would take another cortisol sample, blood sample, and the cortisol should go up. If your adrenal glands don't work because they're being destroyed by Addison's disease, they won't respond to that ACTH that you've injected, and the cortisol won't go up. So that's the SST. We actually do them quite a lot. And just other things as well that would make you think of Addison's is low blood sugar and postural hypotension. So that's Addison's. Spot diagnosis number 2. This is really hard. My housemate couldn't get it, so I don't expect you to get it. But when we were in our OSCE last year, we had a history of a patient with back pain and weight loss. And then we were presented with these blood results. So the things that you're up to concentrate on, they've got high potassium, they've got high calcium, and they've got a high ESR and low HB. I'll just tell you what it is. It's myeloma. So those are kind of like the kind of combination of things that you would think about in myeloma. But again, like, I'm not going to talk to you about myeloma and go into loads of detail about it, but that's just something that kind of that combination of things would make you think about myeloma. So just kind of a summary. Always treat your patient and not the numbers. Always look at trends, and always consider what actions you're going to take. So you get out of the habit of just like looking at blood results, start to think, what am I actually going to do about this? And then I've just done a little slideshow, just quickly. So it's just 10 pictures. If anyone wants or needs to go, they can go. But hopefully it'll be useful. So here's the first picture. They're not all this hard. I'll go through the answers at the end. Actually, the second one is also quite hard. Sorry. Do you want me to go through the answers now, or do you want me to go through? Okay. So what is the condition? It's multiple myeloma, and the formation of the blood cells on the left is called Roux-en-Rouleaux, which is Roulleaux, and then this is serum electrophoresis. So you have the band of IgG. That's just kind of what shows up. So second one. What is shown by the arrow, and what is it the treatment for? So again, this is quite hard. So this is called a peripheral iodectomy hole, and it's treatment for acute angle closure glaucoma. And the only reason that I put this in is just because there's that section about like eyes and ears and nose and throat that you just kind of push to the side, but there'll inevitably be some kind of ENT type question in the slideshow, so hopefully it'll be this. Iodectomy hole, and it's what they use to treat acute angle closure glaucoma. So, how would you classify this ankle fracture and why? And this is purely because in 5th year you do MSK, so it's just something new, isn't it? So this is a Weber-B fracture, and that's because it's at the level of the syndesmosis, which is the ankle joint. So you have web at A, B and C. I think A is above and C is below the level of the syndesmosis. Apologies if that's the wrong way around. So this is when it starts to get a bit easier. So a patient is on CCU, so coronary care, one day post-ST elevation MI. He starts to become acutely short of breath, so you order a chest x-ray. What is the likely complication and what signs are shown on this chest x-ray? So this is demonstrating heart failure following an MI. So you've got the cardiomegaly, you've got the blunted costophrenic angles, and there'll be things like bat winging, and, oh, I forgot what it's called, pulmonary diversion, when the vessels go up towards the top of the lungs. So that's a common complication of, well, not common, but it's something that you could see after an MI, because their heart's not beating efficiently enough. So we got so many ABGs in our finals, so know your ABGs really well. A patient presents to A&E unconscious but breathing. The breathing is laboured, so you decide to do an ABG. The results are as follows. So this is when they won't give you reference ranges for ABGs, so you should know them. But just in case you don't, pH is low, CO2 is normal, PO2 is more than adequate, and bicarb is low. What does this blood gas show, and give 2 potential diagnoses? Yeah, so the pH is low, so it's acidosis, the bicarb is low, so it's metabolic acidosis. So I've just written down 2, but there'll be loads of causes of metabolic acidosis. So DKA, so often you'll see patients with this really laboured breathing because they're trying to blow off their CO2 to try and correct this. And paracetamol overdose is another one, but like I say, there's lots of different causes. So you are a medical student on ICU. You see this lady in a coma. The nurse tells you she can't remember the exact diagnosis, but she presented with hypothermia and hypoglycemia and is now being treated with steroids. What is the diagnosis? So this is myxedema coma due to hypothyroidism. So it's not Cushing's because you wouldn't treat someone with Cushing's with steroids, because Cushing's is too much steroids. I actually saw this in ICU and she did look like that. So what is this piece of equipment and what is it used for? So this is a Senstakeman-Blakemore tube, sorry if I pronounced that wrong, and it's used in upper GI bleed, and it's just basically that balloon bit, the yellow bit, gets inflated and is used as like a tamponade to stop the bleeding. I've never seen one of them be used, but I've only seen one GI bleed, so maybe they're used a lot. So a patient with a long history of type 2 diabetes comes to see you because of changes in their vision. Oh, sorry, this is quite hard. He has previously refused any medical intervention because he denies his diagnosis, but is annoyed now that he can't read the paper properly. On fundoscopy, you see this. Name 3 signs and the diagnosis. When we had a lecture from Dave Harding last year, he basically said that he never did fundoscopy because he figured that there'd only be one picture coming up and he could take the hit. And I think that's quite true, so don't worry if you don't know this. We didn't get any, so it's fine. And I can never see anything with a fundoscope anyway. But on here you can see cotton wool spots, venous bleeding and hemorrhaging, and that's severe diabetic retinopathy. Hopefully you can see that. So you're performing an abdo exam and you see this scar. What is its name and what does it indicate? So the name of the scar is a Rutherford-Morrison scar, or a hockey stick scar, and it's a sign of a renal transplant. And something to remember is that that's just where they put the kidney in, because they don't take the old kidneys out. So you kind of think, like, surely there'd be a scar there, but it's down there because that's where they put the kidneys in. And so finally, because I'm on colorectal surgery, describe this stoma. What type of stoma do you think it is? So it's most likely an ileostomy because it's on the right side of the abdomen, it's spouted, whereas the colostomies are more flush to the skin, because the ileal content's more irritant to skin, so they like make a little spout so that it doesn't come into contact with the skin. And if, just as another point, if there was a bag attached with stool coming out, the stool would be more liquidy as opposed to thicker with colostomies. And when you're describing stomas, you should always document that it's pink, and if you felt it, that it's warm, because that shows that it's working and that it's being perfused. So you would say that this is spouted, it's nice and pink, it's on the right side of the abdomen, likely an ileostomy. This could also be a urostomy, which is when patients have had their bladder removed, they do this really clever thing where they take the ureters and then they put it into like a fake bladder made out of small bowel, and then the small bowel is brought to the surface just like a normal ileostomy, but there's urine coming out of it, and there'll usually be a little stent in there as well. So that's just something else to be aware of. I never had heard of a urostomy until I started work, so it's just something else that it could be. That's it.